now. So we're very pleased to have Zhang here today. Yuqi is a general surgery resident from the Yale School of Medicine who's completing her research years currently as a fellow in the National Clinician Scholars Program at Duke University. Her research goals center around surgical access and rural surgical care. During her time with the NCSP, she plans on receiving a Master's of Health Science and Clinical Research through the Duke University School of Medicine, and she received her BS in biology from Duke University and MD from the Warren Alpert School of Medicine at Brown University. Thank you so much for joining us today, Yuqi.
Thank you, Hannah, for that great introduction. Good morning, everyone. It's a real privilege to be invited to talk with you today about my research around rural surgical care. Thank you so much, Hannah, and to the Rural Health Research Seminar Group for giving me this opportunity. I am working with Tyler Malone, a health policy and management PhD student here at UNC on all of the bypass projects. He joins me today and can fill in any gaps that I may miss. He gave an in-depth talk this past March about one of our projects, so I will focus today primarily on the interim progress and results. If you have any questions, feel free to interrupt me during the talk or drop them in chat, or I can answer them at the end. Here are the disclosures. I want to focus today mainly on 4 parts. First, what is surgical bypass and why is it important? Next, I will briefly touch upon our completed project, which is the scoping review on bypass, mostly as a setup for testing additional predictors with an expanded and more recent claims data. And then finally, I will end with a couple other projects I am working on that are indirectly related to rural surgical care. So what is bypass? What is surgical bypass and why do we care? When I see the word bypass as a general surgery resident, I often think of cardiac bypass or bypass surgery for weight loss. But in this context, it is defined as when rural residents choose a hospital further away than their local community hospital for healthcare. So let's say we have a resident of Montgomery County who needs a hip replacement. They can go to Montgomery's critical access hospital, First Health Montgomery Hospital. But for whatever reason, they don't, and instead goes to Cape Fear Valley Hospital in Cumberland County for that same hip replacement. This resident has effectively bypassed his or her local community hospital. So why is surgical bypass important? Well, I think from a patient's perspective, it really highlights the balance between healthcare quality, or what patients may perceive as quality, and inconvenience. So what do I mean by that? Well, most of our lens on surgical quality is driven by this seminal paper by Birkmeyer and colleagues, who showed that there's a strong correlation between hospital surgical volumes and outcomes in the United States. Surgical volumes are clearly less in rural hospitals in both number and specialties offered. So what might rural patients be thinking when they bypass hospitals? We aren't exactly sure, but we can assume all patients want quality in the form of good surgical care from their surgeons and good surgical outcomes. But they also want the convenience of shorter driving distance and to be closer to their family and friends. So does this mean all surgical care should be done at urban hospitals? Well, not really. All the surgical procedures Birkmeyer and colleagues analyzed were very complex, including abdominal aortic aneurysm repair. This is when you have an outgrowth in the abdominal portion of your aorta, and you have to repair it. They also looked at cystectomy, or removing all or parts of your bladder, nephrectomy, removing the kidney, esophagectomy, removing parts or all of your esophagus, gastrectomy, removing a portion or all of your stomach, and coronary artery bypass, or CABGs. So these are all very high-risk surgical procedures and are extremely complex and specialized. but I argue represent a very small portion of the procedures done in rural hospitals. However, more recent data has shown that inpatient surgeries are performed safely and effectively in critical access hospitals. In fact, Abraham et al. Showed how for common surgeries, critical access hospitals provided equivalent or even better outcomes at a lower price. They studied incisional hernia repairs. So this is when you have a weakening of a part of your abdomen and there's a protrusion of contents that shouldn't be protruding. Colectomies, removing some or all part of your colon, usually for colorectal cancer. Cholecystectomy, removal of your gallbladder, and then appendectomy or removal of your appendix. And I think these procedures probably represent the majority of rural hospital surgical volume because they are very common and definitely more common in the commonly seen in the rural population. So let's switch the lens a little and think about bypass from a hospital's perspective. Well, surgical bypass outlines the balance between revenue, but then also having sufficient patient populations. So surgical revenue provides protective effects against hospital closure and allows residents to stay within their community. This is mostly because surgical revenue makes up a huge portion of the hospital margins. But rural hospital surgical services can be underutilized due to bypass. On the other hand, rural hospitals can't increase indefinitely the number of surgical services they perform because they may not have the volume to support the surgeon and ancillary staff. There's also a huge surgeon shortage in the country, especially in the rural area. In this context, we aimed to characterize rural surgical bypass because it helps us understand not only patient choice, but gives us better clues on all the different decisions that patients and even hospitals have to make regarding these choices. We hope to demonstrate that there is a set of surgical procedures which could be done safely locally, but underutilized because of bypass. So the first thing we did was a scoping review, mostly to get a sense of the existing rural surgical bypass literature. We aim to understand what are the hospital and patient characteristics that affect rural residents' surgical care seeking behaviors, and did this through a comprehensive review of the existing literature to find factors hypothesized to influence patient choice. Tyler went into detail regarding the methodology behind this review, so I will just go over briefly the results. Out of the 6,600 articles that our database search produced, Tyler and I hand reviewed around 4,000 articles and found only 3 final articles met our inclusion and exclusion criteria. This shows that there's a significant lack of current surgical bypass research that is widely applicable to the US population, since the 3 articles utilize data from only 3 states and before the Affordable Care Act implementation. Of the existing research from the 3 final articles, we found that choice is a function of both hospital and patient characteristics. This chart shows the factors that are associated with either increased or decreased surgical bypass probabilities. Next, using what we learned from the scoping review, we tested an expanded set of hypothesized patient and hospital level predictors on more recent claims data, and this is our current project. To study the rates of rural bypass for certain elective surgeries, we conducted a retrospective observational study of rural residents whose closest hospital was located in a non-metro county and who received care for these surgical procedures. The reason we chose this list of 11 surgical procedures is because they all have a decision-making component to them and are among the most common inpatient procedures performed. We excluded procedures that are emergent or unplanned in nature. This is unique from the previous work, which looked at all surgical procedures done at rural hospitals and didn't necessarily differentiate between complexity or urgency or specialties of the surgeries. Each surgical procedure was then stratified based on surgical risk, and we specifically included surgeries in each level of complexity. I want to go through this list of procedures briefly and define some of the more obscure surgeries and also explain the complexity levels. While I do this, keep in mind how they relate to the different surgical procedures Berkmeyer and Abraham studied. So going down this list, a percutaneous transluminal coronary angioplasty, or PTCA, is a non-invasive way to treat heart vessel blockages during a heart attack. It's low complexity, mostly because of its non-invasive nature. A lap sleeve gastrectomy, which is taking part of the stomach away, and in this case, it's mostly for weight loss, and along with gallbladder removal, hysterectomy, and spinal fusion are all intermediate risk because they require a bit more anesthesia and a longer length of operations. The orthopedic surgeries and colon resections are higher risk, mostly because of the prolonged anesthesia and postoperative complications and patient population. And finally, any surgery on major blood vessels will be very high risk. So carotid endarterectomies remove plaque buildup in the arteries in your neck feeding your brain. The cabbage is an open version of the angioplasty. So you still treat blocked heart vessels, but in this case, the surgeon opens up the patient's chest. And it's grouped with aortic and mitral valve replacements, two valves in your heart, because they're often done concurrently. So we used 17 states all-payer claims data from 2014 to 2016, which is provided by the Healthcare Cost and Utilization Project, or HCUP, which is sponsored by the Agency of Healthcare Research and Quality. Our claims data represent a diverse geographic representation of the United States. By comparing the ID of the admitting hospital with the ID of the hospital located closest to the patient's residence, we determined if bypass was present and tested it against hospital and patient level characteristics informed by previous research and clinical knowledge. We analyzed both a linear probability model and a logistic regression model. For those of you who follow stats, as you know, there are some limitations from using a linear probability model. So for this reason, we tested both models, or also known as a sensitivity analysis. Here are some preliminary results. Of the almost 139,000 patients in our sample, the mean age was almost 63 years old, and they were more likely to be female and Caucasian. Medicare and private insurance were the most common payer classes. Here you can see the list of surgical procedures ranked by volume. The most common procedures were orthopedic procedures, followed by spine and obstetrics with the hysterectomy. We found that over 2 out of 3 rural patients who needed surgery bypassed their local hospital. The highest bypass procedures were cabbages and valve replacements, followed by bariatric and spine procedures. The lowest bypass procedures were angioplasties, taking out your gallbladder, and hysterectomy. Next, moving on to the linear probability model results looking at patient and hospital characteristics. So under the patient predictors, we see that our results are consistent with what we found in previous research. Younger patients who are privately insured are more likely to bypass. We were not able to test the virality of our patients. However, we also found that having Medicaid insurance, being African American or Hispanic, or having a higher relative distance to the second closest hospital was associated with lower probability of bypass. The relative distance meant basically the patient distance to the second closest hospital divided by the patient distance to the closest hospital. But being male or living further away from one's closest hospital were associated with higher probability of bypass. The two distance factors basically says that the closer the closest hospital is to a patient, the less likely they are to bypass it. But if their next closest hospital is close to their nearest hospital, they are more likely to bypass it. So all in all, patients are more likely to bypass with a higher density of hospitals because there are more closer choices. Next, looking at hospital factors. Our results were again consistent with those from previous studies. Hospital volume were inversely associated with bypass probability. We found that hospital system affiliation was associated with increased rates of bypass. Our results did not test hospital accreditation or employment of local surgeons, but we did find that as number of full-time equivalents and operating margins increased, the likelihood of bypass decreased. And also, critical access designation or Medicare dependent hospitals were associated with higher bypass probabilities. And the more a hospital was recommended by other patients, the less likely it was to be bypassed. Our project was novel in that we studied an exclusive list of common elective surgical procedures. We found that in comparison to the reference group of total knee replacements, different procedures were associated with increased or decreased rates of bypass. As expected, those with lower complexity levels were associated with lower rates of bypass, while more complex procedures were associated with higher rates of bypass. In this case, incisional hernia repairs was roughly equivalent. There are some limitations to our studies. First, the distance using medical claims data was calculated from the straight line distance based on zip codes of patients' residence and eventual facility providing care. The zip code does not perfectly predict a patient's driving time, given the large variable area covered by each zip code. So this lack of standardization in area covered by a single zip code can lead to potential bias. Second, we were unable to capture bypass rates if patients received surgery in a state that we were not studying, and whether or not a hospital offered the specific surgical service we were studying. We mediated the latter aspect by making sure that we included in our list very common elective procedures that all general surgeons should be able to do. And most importantly, we can have predictors, but that doesn't perfectly correlate with the exact reasons why patients may choose one hospital versus another. But tying this all together, we can draw some preliminary conclusions. First, our bypass rate of 67% is much higher than the reported 20 to 50% bypass rates in the existing literature. This could be due to the increased number of hospital mergers and consolidations that have happened since the publication of previous research, or due to the increased number of states we looked at. We also differentiated between surgical procedures, which previous papers did not. In relation to hospital acquisitions, we found that increased bypass is associated with system affiliation and hospital density. This makes sense because hospital systems will want to centralize lines of healthcare to certain hospitals. What was interesting is that decreased bypass was associated with patient recommendations, which show that online reviews could make a difference, or hospital star ratings or any kind of rating systems may make a difference. Lastly, higher bypass was associated with more complex surgical procedures, which is consistent with the seminal work on outcomes and volumes. However, bypass was still high even for the less complex, more common procedures. So what does this mean practically? Well, I think our work is significant because bypass has important implications for both patients and hospitals. This work allows us to begin to understand just a little bit about the complex process of decision making. And most importantly, understanding determinants of rural hospital choice helps policymakers and hospital administration to explore ways to optimize rural surgical care in a safe and effective manner. With the remaining time, I'll briefly talk about the other projects I am working on, which stemmed off mostly from the finding that there are elective surgeries which have high rural bypass rates. This project is not specifically related to bypass, but rather on surgical outcomes of critical access hospitals. Abraham et al. Show that inpatient surgical outcomes of critical access hospitals are equivalent or better for certain elective surgeries. However, in the past decade, there has been a shift from doing surgeries in the inpatient to outpatient setting. This shift is also represented in the critical access sector, where outpatient surgeries constitutes over 3/4 of all surgeries performed. However, outpatient surgery outcomes have not been studied in critical access hospitals despite this 3-to-1 ratio. We plan to conduct analysis of claims data from 4 states with critical access hospitals, looking at outpatient surgical outcomes of critical access hospitals versus non-critical access hospitals. We have chosen a list of common outpatient surgical procedures and plan to study postoperative morbidity and mortality as outcome measures. We have already done a preliminary analysis of Florida as a state, but we realized that we needed more states due to the due to our lack of power. So we're in the process of buying more HCUP data right now. The other project I'm working on is looking at price variation of surgical procedures across different factors. So there's a lack of transparency in the American healthcare, especially in relation to prices of procedures. The Centers for Medicare and Medicaid, CMS, recently introduced a regulation that requires hospitals to publicly post searchable and machine-readable files of payments by individual payers on their websites. This plan became effective January 1st of this year, and they say that files must list lower and upper bounds and average payers for inpatient procedures for all payers, including Medicare accountable care organizations as well as commercial players. There is a nominal fee for non-compliance, which is probably why hospitals have yet to post their cost reports online. We have already started looking into the price variations of different surgical procedures in relation to hospital type, density, and insurance markets, but we plan to also study price variation of surgical procedures done in rural versus urban hospitals. We want to look at the rates of non-compliance and see if there's a difference in the rurality of hospitals. And the database we are using is a comprehensive list of publicly available cost reports which have been compiled by the company Turquoise Health. So some final thoughts as I wrap all of this up. I came into this research fellowship with an interest in rural care, and I think what I have ended up doing for my projects is very different than what I imagined. However, the entire process has taught me a lot about rural surgery and policy and around the extremely complicated decisions that go into the decision-making process of patients. I know that rural surgery is extremely complicated, and in no way do I think I am solving the problem with my research, but I think my main overall goals are to show how much surgical bypass is happening, identify hospitals, patients, surgical procedures associated with bypass, and demonstrate that the quality of care for these bypass procedures is equivalent in inpatient and outpatient settings in rural hospitals. So I want to thank the Duke Department of Surgery and NCSP faculty listed here. The bypass projects are in collaboration with the UNC Shep Center under the tutelage of George. I want to especially thank my partner in crime, Tyler, who I think is the true brains behind the operation. And lastly, I want to thank the North Carolina Office of Rural Health for their unique and valuable insight. Thank you so much for giving me the opportunity to speak today. I really appreciate your time. My email is here if you want to contact me, and I will take any questions.
Thank you so much, Yuqi. I really appreciate it. I noticed on you mentioned that you were looking into, whether or not the hospital is a system or a member of a system. And I was curious at all if you'd looked at system membership of non-hospital, clinicians or primary care practices, because I think that potentially people are being directed to different hospitals by their, primary care physicians, potentially, who are, if they're part of a system, might be more likely to direct people to hospitals within those systems if that's not the nearest rural hospital.
Yeah, I think that's something that is probably another limitation is you really can't figure out the referral patterns of how primary care physicians will, or who primary care physicians refer patients to which surgeons, because I don't think PCPs are thinking about which hospital may be the closest to residents. They may just be thinking about, from their own personal experiences, this general surgeon had good outcomes, so they're going to be the referring surgeon for patients. There are hospital referral regions, which are these collections of zip codes that Dartmouth Atlas Project had set up. But those were mainly set up in the context of neurosurgery and cardiac surgery, which I think wouldn't apply as well to rural patients.
Yuqi, I had sort of a similar question. The slide where you had listed system membership, I couldn't determine whether those were conclusions from your research or speculation as to why you found the findings you did.
I think it was a bit of both. So we did find that system membership was related to increased bypass. And then we sort of speculated that when there are hospital consolidations and mergers, just from talking to some of the CEOs in these big hospital networks, they talk about how they try to have like a centralized hospital that they funnel all their neurosurgery to, or they funnel all their more complex general surgery to, and they take them away from the community hospitals that are within their system. So I think from there, my speculation is that they start centralizing certain service lines just to make, I think, their referral patterns easier and to make employment of surgeons easier. They don't have to employ as many surgeons, so it's a lot cheaper for them. And I think that sort of goes along with what Mark just asked about workforce implications. I think for workforce within, I don't know what kind of workforce you're referring to, Mark, but I think within a system affiliation, one of the main problems with workforce is that they can't find enough surgeons who will be willing to go into their smaller community hospitals within their network. So what they do is they'll then hire less surgeons that they centralize into the main hospitals, and then they will funnel the residents in the community hospitals to go to those main hospitals. So that will then sort of kill two birds with one stone. But they're not really thinking about that these community hospitals are often a big portion of the community. They're really the sort of central workforce of a rural community, and there's a lot of support and networking for patients in the community.
Since you answered my question, I'll ask another one. Have you thought about, and I don't know if there's a taxonomy that works this way, but let's call them urgent versus not elective, but
Yeah.
centralizing some things may be less important than appendix rupture kind of.
Yeah, that's a great question. So you're talking about basically the acuity of of surgeries. So in a lot of claims data, they'll set up the admission surgical code will say elective, urgent, or emergent. Urgent and emergent, we sort of categorize under unplanned. A lot of, so that's your, like you said, appendectomy, appendix ruptured. You can't really plan for that. The reason why we chose the set of procedures that we did is because all of these procedures are very elective in nature. So like even the very complex surgeries like cabbages and carotid endarterectomies, patients plan for those. They're not like it's very rare that you have an emergent cabbage. That just doesn't happen. You know, you plan months for a cabbage, you plan months for a carotid endarterectomy, you plan very long time for colectomies, definitely for hip replacements and knee replacements. Those are all elective. The only one on that list that may be semi-elective is a hysterectomy because there are women who can go into like emergent, needing an emergent C-section, but that's also a pretty small portion. So most of the surgeries that we looked at were elective and hopefully have a patient decision-making process to them. So Ariana said, it's striking. Yeah, I agree. I think Tyler and I were both quite surprised at how high the surgical bypass rates were, just because they were a lot higher than the previous reported ones. And then, so I think Emma and Zhang has questions. Emma, do you want to go first?
Yeah, is that okay?
Yeah.
I wasn't sure if I was before Zhang or not.
Oh, I wasn't sure. It's okay. I'm going off my little
Yeah.
Go
mosaic.
ahead, please, Emma.
Oh, thank you. So my name's Emma Watson. I'm a medical director of a rural health system back in Scotland, and I'm a visiting fellow here at UNC. And you know, I thank you for your research. I found it really fascinating, and I find the question of bypass fascinating because that isn't a thing for certain procedures in my country. And I say for certain procedures particularly because when I look at the list that you presented there, many of those procedures would not be undertaken in our rural hospitals. The system would bypass you to the biggest tertiary center because your outcomes are going to be better. But there were things that people were bypassing for that actually are as good. And I think there's more than the more evidence in the literature than you described on outcomes being really much better actually in the rural system, particularly the softer outcomes for patients around being close to home and feeling part of their community. So I wondered if one of the things you're going to look at is which procedures shouldn't be done in a rural hospital. And, so I would argue from a patient safety perspective that there should never be a cabbage undertaken in a critical access hospital.
Yeah.
And so just take that off the table. But I appreciate in your market industry that isn't the way the thinking is. And I'm just keen to hear your thoughts and perspectives on that.
Yeah, I agree with you. I think what I was hoping to sort of achieve is to show that on the other spectrum. So the common surgeries that aren't being done in rural hospitals that can be done in rural hospitals, because I think that's really important for both patients and rural hospitals. The list of surgeries that shouldn't be done in rural hospitals, I think the Leapfrog group has very nicely outlined. So Leapfrog group is the group of physicians and I think healthcare, health policy makers that came from Berkmeyer and colleagues' paper. Basically, they have a list of surgical procedures that are very complex on their website that they highly recommend should be bypassed to large, high surgical volume hospitals. And they have written papers afterwards showing how after the Leapfrog group helped patients bypass X number of these procedures, they were able to save or they were able to prevent X number of deaths and complications. So I think those, the procedures that they list in those, and those include Whipple procedures, or basically pancreas tumor resections, cabbages, esophagectomies. So all the really complex procedures I listed before, those I think should not be done at rural hospitals. And I also think it's good for the rural hospitals not to do them, because to hire such a specialized surgeon is extremely expensive. To have the ancillary staff is extremely expensive, and they don't have the resources to take care of complications. And they usually will refer them to a larger hospitals for post-operative care, which then disrupts the continuity of care for the patients. So I think Zhang and then Susie.
Hi, Yuqi. Thanks so much for your interesting presentation. I'm a PhD student at UNC in health econ. So I have some curious questions. I want to follow up with your study. I'm thinking if it's possible to have some implication to post-surgery like services for rural hospital, like for some research, say like post surgery, like rehabilitation services after doing the surgery in tertiary or big hospitals. Probably they come back to the rural area, and for the second or third, the later following up services, they may choose some local hospitals nearby. So I'm thinking whether the bypass may have some possibility to extend to those group of people or identify their following up services after surgery.
Yeah, I think that actually may also go really well with what Ariana had posted. Is I totally agree. I think the follow-up, so at Yale, one of the things that we hate seeing is a very complex surgery done at a community hospital. Some disaster happens, then they come here because we don't know what happened originally. We often can't get the op report, so we don't really know what the surgeon did. And it's not like we never fault the community overall or general surgeon. It's more just that from the other perspective, it's extremely complicated. So I agree. I think being able to study the follow-up care of patients who have bypassed is also really important, because you're able to see where did they end up going for rehospitalization and reoperations. And if you're able to show that, look, for these common surgeries, they don't actually have that many follow-up or like rehospitalizations complications. And if they do, they're taken care of safely in the rural hospitals. But for these complex procedures, they actually do worse, not only because they have to be transferred, but because the care is discontinuous. This is a bit harder to study just because you need multiple data sets for the same patient. So we're doing this. So the project that I'm doing with outpatient surgery, critical access hospitals, we're doing that, and we're able to temporarily follow patients because we are in the process of buying 3 data sets. So the data set that Tyler used for this project is the state inpatient data sets, which is only inpatient claims data. HCUP also has state emergency department data sets and the state ambulatory surgery data sets. So what we're doing in that project is we're using all three databases for one state over certain years. And what you can do is you can have a cohort of patients, and then using the different data sets, you can track them temporarily as they utilize different services. So our initial cohort are all the surgical patients who had outpatient surgery. And then we use the ED data set and the inpatient data set to track their ED visits, their reoperations and readmissions. So that would be really cool to do also for the bypass patients, but it gets extremely expensive. So like one state just for those 3 data sets can run up to $5 to $6 grand. So like 17 states, and that's just for 1 year. So like 17 states would be like astronomically expensive, but it's a great idea. And Susie, I'm sorry, I think you've had your hand up the longest.
Just curious, it's a small question about the complexity designation of a procedure, and if you know anything about how it maps with patients' perception of complexity, and if, I mean, this wouldn't be something you can do with your data, but if someone else has done something along these lines, and if that would differ by procedure potentially, and could explain if it matched more accurately for some procedures, that could be a reason why bypass was like didn't increase or increase in ways that you thought it would for some procedures or not other procedures, or just anything on complexity. And
Yeah, that's a great question. I do know a little bit. I'm not sure why. I think somebody had studied it, but patients always perceive oncology procedures to be very complicated. So anything that relates to cancer, they think is very complex and anxiety inducing, which I think makes a lot of sense from the patient's perspective. You know, you have cancer, and from a surgeon's perspective, all cancers are not created equally. So when we always joke that you're gonna die of something else before you die of prostate cancer, or before you die of thyroid cancer. But patients who have thyroid cancer and prostate cancer feel very differently. So for us, like a thyroidectomy or taking out the thyroid, or a mastectomy, taking out portion of the breast for breast cancer, we think is a very, not simple, but like a very straightforward procedure. Like the complication risks are really low. You can do them very quickly. Like you can probably take out a thyroid in an hour or 2 hours. But on the patient side, they think it's a very complex procedure, mostly because of the implications that the cancer brings. So yes, there is a mismatch. I don't know how to quantify that in a research sense, because a lot of this is just clinical, like what I've seen clinically. So Mark, reuse H-cup can be cheap under certain conditions. Yeah, no, I agree. Then the other thing is like, so it's 2022 almost, and then the H-cup data that I think we're using in this project is already over 5 years old now. And I think that's the other problem, is like buying new years of H-cup data is then even more expensive, because and then you can't keep on reusing the same old data set, because I think once you hit over like the 5-year mark, journal articles say there's been so much change that what you find may not be applicable to the current population.
Yeah, it was more a public service announcement for the students on the call.
Oh,
Students in particular, I think, get reused for $0.
yes.
So looking for existing data sets that rather than saying, oh, I gotta go find 20 grand to buy these, you know,
Yes.
10 states, get a friend who's already purchased.
Yes. And then if we're doing public service announcements, I also, like, from my 1.5 years of doing this, I've also just been amazed at the lack of data sharing and just central data repository there is for these data sets. They're extremely expensive, like mind-boggling expensive for stuff that is just readily available to these places. And then to share them between university is impossible. So like, I have some other projects looking at Medicare claims data with University of Michigan, no can do in sharing. And then we wanted to use some American Health, like the AHA survey data set between Michigan and Duke, couldn't share, had to buy new ones. It's like $5 grand a year. And it's actually like just crazy. But if anybody ever needs H-cup data for I think I plan to buy Florida, Nebraska, Iowa, and Maryland, SID, SASD, SEDD from HCUP. If you ever think that you can utilize those states and years, please shoot me an email. I will add you to the DUA, and maybe we can start sharing.
But Tyler, we've just bought the SCDS for several states, so hopefully we're not buying it twice.
So I think in Yuqi, in your case, that data you mentioned, I forget who would all currently be listed on that DU, because you're right, to George's point, you wouldn't want to overlap, although I suppose if they're distinct projects with distinct programmers or data analysts, you might still need the separate data sources. But we could
Is that true, Mark?
George, you broke up.
Sorry, is that true? What that you have to buy this? You have to buy multiple versions of the same data set for different projects?
No.
I think it depends on where the data lives. So like if UNC bought it under UNC, then Duke wouldn't be able to use it. So I wouldn't be able to use the 2019 SCTD data, unfortunately, Christy. But
Tyler would.
yeah, but because it would be a different project, the Duke analyst wouldn't have access to it because she's affiliated with Duke. So there's a lot of these loopholes that HCUP has put in to prevent people from utilizing data sets. So the data that I'm planning to buy is using personal research funds. So I'm hoping that that means it lives under my name. So if that's the case, I wonder if sharing between different institutions is a lot easier.
And yeah, that was more what Yuqi had just outlined there, George, was more what I was referring to about a Duke University analyst can't necessarily easily access the SID data that lives at SHEPS. And Yuqi, just I think Tim also had a good question in the chat. I don't know if we had a chance to get to.
Oh yeah, if a hospital has 0 cases in a year. Yeah, I agree. I think the part that was hard to figure out is how many cases they had in a year for a certain procedure. So we were unable to figure out exactly the hospital surgical volume. And so like we analyze hospital volume as a separate predictor in addition to the FTEs and operating margins.
Just to clarify though, Tim, on your question, so we did not consider it to be a bypass if there was evidence that a hospital had performed a given surgery in a given year. So if someone's local hospital had 0 instances of a incisional hernia repair, but it was their local hospital, and then they went to the next closest hospital to get that surgery, we didn't consider that a bypass in our data because there was no evidence to suggest that the local hospital offered that service. So we did take some measures to differentiate between true bypass, I guess you could say, or non-avoidable bypass, as it sometimes is called in the literature.
And Mark, what do you mean by non-public data, that they need non-public data? So if I need non-public data for my project, they would. Sorry, you chew.
Sorry, so like, well, not every SID has the hospital identifier. Not every SID releases resident zip code, but those are buried in the file somewhere. And HRQ is, and I think HRQ, and I agree, is that HCUP is really underutilized, and the team there that lead the HCUP development would love to collaborate with people on ideas. And basically what they say, we have the data, we can see things in the data that no one else can see. If you have a wonderful idea, we should partner, because we can get into the data to see these things that are protected, or maybe it's day of week, or other things that are in there somewhere, but they just don't release.
So just like email them with with a project idea.
Yeah, and if you want, I'm happy to connect you. They did a session on rural hospital mergers and closures at a panel at Academy Health last year, and that was one of the key takeaways. And so, like Joanna and others there, I think would love to chat if you have something.
Oh yeah, can you forward or just connect me?
Yeah,
I haven't bought it yet, so I would love to save 10 grand if I can. Thank you.
Eugene, just two comment, well, a comment and question, I guess. You made a few comments about workforce and around the supply of general surgeons. I think we might want to include a small discussion as well that what I've heard in the last year in particular is that there's also an anesthesiologist supply problem.
Yeah.
And in the last year or two, there's been a real surgical nurse and ICU nurse problem as well. So it's a very, and surgery may not be provided for one or more of those, all three of those reasons, or two of them, or one of them. I think it's a very complicated workforce situation.
Yeah. Absolutely. Because you need all of them to do surgery, or 100% anesthesia. And then obviously the surgeon, I think it's not even just rural hospitals that have a lack of these nursing workforces. Like at Duke, they are down by so many nurses that they're offering like traveling nurses a very, very generous hourly wage. And like they can't do their full surgical capabilities because of the nursing shortage, because you also have to take care of the patients post-operatively. So I think just like how there's a supply chain demand problem right now, it's also in the medical sector.
Yeah, there's no question. I mean, UNC Health has got 1,100 open nursing positions right now. Which leads to my second question, though, which is that I think reviewers are probably going to say, great study, what will be the effect of COVID? Are these relationships going to be anything, will the post-COVID findings be similar to what you found, or how do you think COVID will have affected your study?
I think COVID would have made bypass less because nobody was getting surgery during COVID. So all elective surgical lines were basically halted when COVID started. So at Yale back in March, when we had the first wave, we basically stopped operating. The only times we operated were for emergent surgeries. Sometimes even like appendectomies, we'll try antibiotics. But so it was for very urgent operations that we would open up OR rooms, because at that point there was no testing, or like there was no reliable testing. So we assumed every patient had COVID, and having a COVID OR it was like insane. The amount of stuff that you had to put on to get into the negative pressure room. And there's only so many negative pressure rooms in the hospital. So I honestly think bypass decreased because nobody was getting surgeries anywhere. And I would argue that it's not a great time to study bypass because all the effects are mitigated by the lack of surgery. Ariana,
do you think you could argue that after the effect of COVID is largely past, that bypass might be worse because rural hospitals having greater trouble recruiting nurses and surgeons than they did before?
It could be, or it could be better because the other hospitals are now, they have a backlog of all of their patient procedures that they now have to do. So that means that they may have less operating available spots for elective procedures that are being referred from the community. So honestly, I think I can argue both ways. Ariana, in terms of HCUP data structure, do you mean just what kind of data that they have, or?
Oh, I was referring to the AHRQ call for collaborators.
Oh.
I feel like I would need to get a better sense of the HCUP data set structure before I reach out to anyone. It wasn't a question for you. I was just responding to what Mark was saying.
Oh, I see.
I thought your talk was great.
Oh, thanks.
Well, we're a couple minutes to noon, so unless anyone has other questions, I think we're probably good to wrap up here. Thank you so much, Yuqi.
No, thank you for asking me. This was really fun.
An important biographical note that was not made is that Yuqi is a Canadian.
Yes, I am half. Yes, I'm half Canadian. I grew up in Ontario, though I can't stand the cold now, so I don't know if I'm a true Canadian, George.
You and me both.
Yeah, I do like ketchup chips though, so that's one thing I do miss a lot. Well, thank you so much. Hope everyone has George full. You should have me a quarter. Nice. And thanks, Mark, for that introduction. I appreciate that.
Really good presentation, Yuqi.
Oh, thank you. Thank you. Thanks again. Bye.